And again, once we analyze these images, then we say, okay, well, look, I feel that you may be having, say, headache related to malaria. Now, I have to prove that this headache is fitting with malaria. So you may have had some fever, you've got a bit of headache, you may have malaria. So I want to prove that there's malaria parasite that is available in your blood. So I would take some blood and send it for pathology examination. That's the pathology test that you have. So the pathologist would then try and tell me, yes, there's malaria parasite found, malaria antigen positive, and that's how we come to a diagnosis. Okay, so simple again. I mean, for people who've been through a medical course, this is very humbling that we as doctors would actually do nothing but analyze a set of symptoms, try and put it into different patterns as fitting the different physiological phenomena that the body is doing. And then once we have that, we would do an examination of the different system, try and confirm our hunch, and then have a provisional diagnosis. So that's without your examination, without your investigations. And then we take help of investigations, which would be imaging, which would be pathological tests, and then come to a diagnosis. So up to now, I have diagnosed that we or you have had malaria, and that's caused the headache and a bit of fever. What next? Well, the next thing is, okay, now we've got a diagnosis, but we've got to treat it. Yeah? And for that, there's some historical data that we all have that we are privy to. When you're studying medicine, you know that, okay, if someone's got malaria, you give chloroquine. Yeah? Because people have used it, and it's been found to wipe out the malaria from your body. And that's what I, as a doctor, would say, okay, fine, have the chloroquine tablet, this is the dose, and you should be cured of your malaria. Now, once you go through that process, if you're cured, 8 or 7 out of 10 would be cured, and you're all happy. This doctor is good, he's diagnosed my malaria, he's done the appropriate tests, he's given me the chloroquine. However, 3 are not cured by the chloroquine. And that's where this doctor is only 70% precise. There's a 30% lack of precision that this doctor has. Now, what precision medicine is trying to do is trying to improve this 70% to as close as 100% as possible. That's as simple as it can get. So let's try and see what developments has happened in the last so many years such that this precision in number 1, my history taking, precision number 2, my evaluation, precision number 3, my imaging and pathology, and precision number 4 in me trying to give you the best treatment has improved. Now I'll tell you a story. It's actually a real fact. It was in 3rd year of medical school. One of my friends developed malignant malaria and was given medicine, and the patient died of hemolysis. Now there's something, and because the patient was given primaquine, and primaquine given to someone without checking for a deficiency of an enzyme can actually cause death. So this colleague of mine died of hemolysis. And at that point of time, I actually questioned as to why do we not test everyone for that deficiency prior to giving this medicine. Well, now it is routine. At that time, it wasn't routine because the pharmacogenetics part was just evolving. Now, that's a term, again, that you've got to try and remember when you come across precision medicine. So pharmacogenetics is how anyone's body would handle a given medicine. Say, for example, each of us, and about 40 people in this room, if 40 people take this primaquine tablet, 38 wouldn't have anything, no problems. 2 of us will actually have life-threatening condition called hemolytic anemia and die. Now, this hemolysis can be prevented if we can do this blood test and find out your body is not going to digest, or in a very colloquial term, not going to metabolize the tablet that I give you. So what pharmacogenomics is trying to do is to try to identify, prior to giving you something, being a bit more specific, trying to identify whether this tablet that I'm giving you is going to be safe for your body to handle. That's about it. That's one part of being precise. Okay, so these are the four different sort of ways that I as a clinic on a day-to-day basis, when I see a patient with cancer coming through, these are the 4 things that I do. Now let's try and go. I think we've discussed all these. So, when a patient mentions the symptoms, how can I be a bit more precise? So say, for example, is there any familial cause? Is there any other related associated physiological system that's been affected? Anything? Is it one system disease, multiple system side effects? So is it headache associated with fever? Headache associated with nausea, vomiting? This is what I would try and look at. Similarly, I would analyze the symptoms, and like I said, I would do these investigations that, either an imaging investigation or investigations that are otherwise pathologically done. And then once we find the problem, we then give you the treatment, and the treatment is meant to restore the function. So there are 2 treatments that we give you. Number 1, if someone has fever, the first thing all of us do is to take paracetamol, because that's something that all of us do to try and get an acute condition under control. So that's a symptomatic treatment. However, the main treatment is to try and identify where it has gone wrong and give you a medicine that would actually fix that organ. So these are the 2 treatments that I can think of that we usually give you. Oops. Okay, now once we can come to cancer, cancer is often treated, and because I've been told to focus on cancer and I'm most comfortable focusing on that, is that we treat cancer. Cancer can give you, say, a lump as a symptom. So how do we treat that? First and foremost, yes, we take a history, we do these tests, we confirm it's cancer, and then we can give you all these treatments that there are. Now these treatments are, medications can be thousands. Surgical excision can be done in many ways. Other ablative therapy, supportive therapy. Now, the point is, and the main thing I want to drive is that what we are trying to do more and more over the last few 100 years is try and be a bit more specific in managing a type of disease, and this is what precision medicine is all about. So let's think of cancer treatment. Number 1, confirmation of diagnosis, and what is important is that we find the cancer origin. So say for example, we get asked, is cancer curable? Sir, can I get my cancer cured? Now it depends on many things. First and foremost, where has the cancer started from? Has the cancer moved to other parts of the body, or is it one organ that's affected? Are there many lymph glands that are affected with it? What is the stage of the cancer? So if you look at this, so basically what we are trying to do when we see a patient who's got cancer is that number 1, confirm the diagnosis and its site of origin. You will often find that sometimes patients come on and we cannot find the diagnosis of cancer or the site of origin. And that's when we try and do more and more tests, because the treatment of cancer is very much dependent on the site of origin. And we're again trying to be more precise over here. Why don't we treat? Yes, we can give you chemotherapy, radiotherapy, surgery for anything. But we are trying to be more precise to try the origin of the cancer is being looked at, and that's how we want to manage your cancer. I want to say this once more because you will often find that when you go to a clinician with a suspected lump or a suspected cancer, the first thing that they do is tell you, this is cancer. Let's get treatment started straight away. It's going to spread. That is to try and terrorize you. The first thing that one should do when someone has even a hunch of diagnosis of cancer is to, number 1, find out exacts, because cancer is not it doesn't respond to approximation. You have to be exact in your diagnosis. Where has this cancer come from? What is the disease burden? And then what are the different types of these cancers? And we'll come to that. I've got a few slides to examine and emphasize to you what we mean by the different types of cancers. In general, and I'll give you a sort of very general dictum over here. In general, if the cancer is related to a organ and its region, say for example a head and neck cancer in the tongue and lymph nodes, or the breast and lymph nodes, or the bowel and lymph nodes. So if it is one area related, it is mostly curable. doesn't mean that it all gets cured. It means that curative treatment, when given to these patients, has a chance of curing a proportion of them. Now again, remember, we are talking about precision medicine over here. When we are saying it's a proportion, we are talking about statistics. What we are trying to do in precision medicine is to try and find out how can we improve the likelihood, improve the chances, improve the precision of the treatment such that we can say, yes, in this type of cancer, the cure rate is going to be higher, or the side effects are going to be low. That's what we are trying to do in precision medicine. So in general, like again I said, so confirmation of the diagnosis of cancer and its origin, identification of the burden. So, all these PET scans, the CT scans, the MRI scans that often you get through. Yeah, it's mainly to try and find out the disease burden. Where has it spread? How big is it? What is the volume? What is its nature? And then once we identify the cancer type and the burden, then we see if the cancer is limited to one area or it is moved to multiple areas. If it's moved to multiple areas, which unfortunately is the case in many, many cancers, unfortunately it cannot be cured. At that point of time, we say that, okay, disease treatment is to try and reduce the tumor burden and buy you quality time to increase the time. However, if it's limited to one place or one region, the treatment is curative. We try to eradicate that cancer. Okay, so let's now again give you a clinical example. A cancer which is very common in our country, breast cancer, the commonest cancer in women. So this is, I treat breast cancer and head and neck cancer, and honestly, every clinic I see patients like this. 55-year-old lady comes with a history of an increasing left breast lump. Yeah. Now, whoever is not even a sort of medical graduate, can actually visualize this. A breast lump which is increasing in size, patient is alarmed, and this patient comes to a clinician. So at this point of time, if the clinician is rogue, what he or she is going to do, say, oh my God, this doesn't look like right, let me try and take a bite of it, and then we'll give you this, we'll give you that. But like I said, that is the wrong thing to do. So all of us now know that we have to be more precise in number one, the diagnosis, and number two, in the staging of the cancer. So what we then do is, let's look at the algorithm. So, I would take a history, and over there, a range of symptoms, signs are analyzed. So, my head analyzes once I go through the history, how long have you had it? Is there any family history? Are there any associated risk factors? Is there anything else that suggests that the patient has had a trauma in the breast? Could this just be a hematoma in the breast? Is this a benign, has there any past history of benign fibroid adenomas? What is the age of the patient? So as I see the patient and discuss, my brain in the subconscious level starts analyzing these symptoms. And then a provisional diagnosis is made in my head before I go and examine. So I think, oh my God, this history doesn't fit right. It's too long for it to be a cancer. There's no family history. She's otherwise very fit and well. No pain, no bleeding, no discharge. Unlikely. Let's go and have a look. And that's when my history is complemented by the clinical examination. So that's how we try and improve the precision. Now, it is a bit of a dampener that I am going back just to the history and the clinical examination and saying that that's how we are precise. But honestly, that is exactly what should be done, and it should, give you the highest precision. So you go and examine, and you find out, yes, this lump is a firm to hard lump. There's associated lymph nodes, and I'm worried that this patient does have a cancer. That's my worry. That's my provisional diagnosis. So clinically, I am worried that this is a cancer. And then, there are no brownie points, but one of you will tell me what should be done next. Once I'm worried, what is done next? We do? Sorry? Investigations. And the investigations are of two types. One is in, that's right, one is in imaging. So, we would like an image. So, which if that's something, your eyes should light up when we hear image, because image is something that you can analyze on a computational basis, and we'll come to that. So, imaging. And number two, we take a biopsy. Yeah? Now, just think, what are we doing when we take this image and when we do a biopsy? What are we trying to do? So when I see the image, what is the radiologist trying to tell me? Absolutely correct. A bit more, I mean, that is a very, for a doctor, that's a technical answer. For a, sorry? That's correct. So basically, we are trying to look at what is new in this image that shouldn't be there, isn't it? As simple as that, yeah? And if there's something that shouldn't be there, what we are trying to identify, microworld, macroworld, or whatever you're talking about properties or texture of the image, or the different features of the image, is that we are trying to find out how this fits into a pattern that we know, isn't it? So if this is this, if there is speculation with microcalcification on a mammogram, this is likely to be cancer. Yeah? So a human brain is analyzing the image and telling me that, look, microcalcification, speculation means cancer. That's the algorithm that the brain is following to report. Yeah? So the brain has seen hundreds and thousands of images. It has read about the properties of images, and that data is fed into the brain. So what it is doing, it's looking at the mammogram and saying, whoop, and then within a microsecond, it's scanning all this and saying, this is new, this has got speculation, microcalcification, this is likely to be cancerous. Similarly, for a biopsy, what are we trying to do? The biopsy is taken, a slide is prepared, it's looked at by the pathologist. And the pathologist is also doing exactly the same thing. It knows how a breast tissue looks like. It's trying to find out, now again, based on its knowledge, on the previous pattern that it's seen, that look, this is looking like a lobular carcinoma of the breast because it's Indian filing pattern. Again, that is what the brain is doing. That is what the pathologist is doing. So far, so easy. Yeah? Are we all happy with this rationale so far? Yeah? Okay, so basically, in general, what we are doing the images, in general what we are doing is doing the pathology tests. So your clinical diagnosis has to be complemented by the radiological and the pathological diagnosis. Say, for example, your clinical diagnosis is of a headache, of a brain tumor, and radiologically there's nothing in the brain. Pathologically they're saying, well, there's nothing, it's normal brain tissue. Obviously, your clinical diagnosis needs a revamp, isn't it? So it all has to corroborate and all has to complement each other. And each of the above are equally important. It's not that, the radiology is less important than the pathology or the clinical examination. And therefore, incorrect diagnosis will lead invariably to incorrect management. So as we were talking about precision, the initial preparatory stage of whether this is a cancer, what is the volume of cancer, and a few more information on the cancer is the most important thing that we need to know before we go ahead and treat it. So if someone ever, friend, family, whoever it is, has to go to a doctor and has to have the investigations, unless it's a real long wait, I think it's always important that we wait and find out these issues before we go ahead and treat. And now you know what the rationale is. Okay, now a sort of diagnosis of breast cancer is made, and the triple assessment is exactly the assessment that you all did. Clinical examination, radiological examination, pathological examination. That's what we do in breast cancer. Triple assessment is done. A hard breast lump has come back as a BI-RADS5. Now again, we are coming to the next step up that you need to think of as a technical person. So basically, these patterns that we recognize, these patterns are being termed or clumped in a specific risk category. That's what it's doing. So it's saying if there is microcalcification, if there is associated speculation, then we will say it is BI-RADS5, which is equivalent to cancer. 95% likelihood of cancer. Remember, an imaging diagnosis cannot be 100% because it's an image. And always remember, there can be optical illusions. So a CT scan, a PET CT scan, MRI, X-ray cannot give you a 100% diagnosis of cancer. So a good doctor is always going to ask for a tissue diagnosis. So some biopsy, looking at it, confirming yes, this is cancer, is what we would need as a 100% gold standard. All right? So this BIRADS classification for mammography is basically a risk stratification classification for mammography. Similarly, for CT scans, there are certain classifications based on the tumor size, the nodal status, the metastases. It's called the TNM classification. And a biopsy is done. Now, when we treat breast cancers, or say for example 30 years back or 40 years back when we used to treat breast cancers, it was like, oh my God, you've got a breast cancer, you need chemotherapy. You need operation and then chemotherapy. But again, over the last 4 or 5 decades, understanding on breast cancer has improved. And that's what we call as understanding the tumor biology. That's how we're starting to get more precise. Not just with better precision of images, with digital radiology, we can actually identify small lesions in the breast, but also with pathology, we can actually categorize the type of tumor. Now how can we categorize tumors? You know, this is cancer. A cancer is something that is growing without any control. That's as simple as it is. It's growing, it's like wild bushfire. There's no control. You try to control it, you burn your hands. But you know, different bushfires, now we understand, have different ways of controlling it. Similarly, there are different characteristics in the cancer that we try and look at. And that's how we get more precise. And that's what tumor biology is all about. So basically, you will find that many of you, when you see anyone with a breast cancer getting a report, will actually have a report that, you know, you have a grade 3 invasive ductal carcinoma, ER/PR positive, HER2 negative, Ki67 50%. Now, you know, for the non-medics, this is Hebrew. This is, oh my God, this is, it's a cancer, what can I do? Yeah, that's pretty simple, yeah? Even for medics, some of these things, you know, when you were doing your MBBS, maybe some of these things weren't evolved enough. So Paramita, on a day-to-day basis, when she gives me a report, she says, you know, it's a grade 3 ductal carcinoma or mammary carcinoma, ER/PR positive, HER2 negative, Ki67 50%. The way I explain it is that the gradation of a cancer is how differentiated a cancer is. So basically, if a cancer is taking a long time to grow, it is differentiating into something. So when we start off growing as a fetus, yeah, we have undifferentiated cells. God has then given us different mechanisms over time to differentiate. So a set of cells starts to differentiate as intestine. A set of cells starts to differentiate as skin. So a more differentiated cell is likely to be more functional. A less differentiated cell is likely to be more disruptive. Grade 3 means a lesser differentiated cell. That means this cancer is likely to be more aggressive to me. And the cancers are graded in grade 1 to grade 3, often. Invasive ductal carcinoma is a type of cancer. Again, so just look at what we are trying to do is we are trying to now look at the morphology. And you know, when she's going to talk about computational pathology, she's going to try and tell you a bit more details on how she does the morph. So invasive ductal carcinoma is a type of breast cancer. And then we come to the biology. So these were the morphology. This is how she's looking at, you know, from the top. She's looking like a differentiated, not looking like a differentiated. The pattern suggests that this is a ductal carcinoma, not anything else, not a lobular carcinoma. And then we talk about ER/PR positive. What that means is that we are trying to look at the biology of the cancer. What are the switches that this cancer has? By switches, we mean that, you know, just like, you know, when we were trying to get the lights off over here, we actually got the switches to sort of turn off, isn't it? The lights then turned off and we could see the slide. Similarly, cancers have switches, and these switches are called receptors. So what these are, this ER and PR, or estrogen and progesterone receptors, are active in this cancer. So we are saying that it's estrogen and progesterone receptor positive. The next bit is another switch called a HER2 switch. Now a HER2 switch, when it is present, makes the cancer more aggressive. And the last one is something called a Ki67 index or a Ki67 index, which again is a marker of how fast the cancer is growing, how fast the cells are turning around. A Ki67, which is around 80, 90, 100%, is real fast. A slow growing cancer has a Ki67 of 5, 10, 15%. So this cancer is looking like, a bit of an aggressive cancer with estrogen receptor positivity, HER2 negativity. Now this ER, PR, HER2 and Ki67 are absolutely key information that I want when I start treating a cancer patient. Because for each of these positive switches, I have a medicine that I can give to target and switch that and sort of turn that switch off. That is what targeted therapy is about. So you all heard about targeted therapies. So if a receptor is present, to make or to pacify that receptor, if you give a therapy, that is targeted therapy. And that is how we are becoming more precise. Understanding the biology of the disease and giving a treatment which is more targeted. Yeah. Right. So, the point I'm trying to make is that as a clinician, I don't only look at what someone is saying like that. I'd like to look at someone's disease biology, analyzing, and the point is to try and increase the chance or increase the statistical likelihood of my therapy responding. And that is how I'm trying to be more precise. And to be more precise, I need more inputs from my colleagues, from Paramita, from radiology, and try and understand how I can use the newer drugs that are coming up, the newer targeted agent, to try and analyze all these symptoms and signs and investigation to give the best treatment for the patient. That is what it is all about. Now, let's look at a few things that you actually can't see any of this. I mean, can you actually see anything over here? No, on the left. You can't. Well, basically, this was trying to illustrate to you how we recognize a cancer on a mammogram just by looking at a pattern. And this is what I told you that we do a risk stratification based on image analysis. So that's the risk stratification that we have, the BIRAD scoring system and the risk stratification that we have. Now each of these has its own flaws. You as technical experts are going to do more research, image analysis, and find out how we can improve these. Cancer imaging has improved. It was initially two-dimensional, three-dimensional, reconstructed images, MRI, and now metabolic images, FLT PET, FDG PET. All these data is available for us when we go ahead and take more precise decision. Now then, this is a study that we did way back in 2012. So what we did is, well, it was actually done back in 2009. It was published in 2012. So what this study is to try and prove the incremental value of doing an extra test to try and improve the precision of a treatment. So what we did is, in head and neck cancer cases, we tried to find, well, when someone has cancer, do a CT scan, because we want to know where the cancer is, how big the cancer is, and then treat. But then PET-CT was just evolving at around that time, and I was then a consultant in Newcastle upon Tyne, and what we did is we wrote up a grant to try and see what is the exact benefit of doing a PET-CT on top of doing a CT scan in patients with head and neck cancers, to try and find out if there's a real benefit or is it just a hoax. So this is what we were looking at, and what we found is that on a CT scan, what we was identifying, a CT GTV is a gross tumor volume, and that's the one in blue, while a PET CT GTV is the one in yellow. And the PET is actually identifying a much smaller area of the tumor, and that is the real tumor. What we are looking at on a CT scan is a much bigger area, because we are less confident on what cancer is, and that's how we actually showed that using a CT versus a PET CT, we not only identify tumors much more precisely in a small part, but also identify nodes that we would otherwise not identify when we are doing a PET CT scan on a CT scan. So a PET CT scan identifies more nodes, identifies geographical miss, so new cancer areas are identified, and that's how we are becoming more specific. There you go, this is a geographical miss. We wouldn't have treated this if we haven't done the PET CT, so again it's a geographical miss area. Again, an area that is being missed just by treating on a CT scan. And similarly, things have evolved on pathological analysis. And now, the next thing on pathological analysis, I mentioned to you that Paramita and her team often gives us the ER, PR, HER2, the grading and all these stuff. But just imagine, if any of us went to the doctors with a friend or with someone we know who has a breast lump, biopsy's been done, Paramita says that this is cancer, while actually it is not cancer. Just imagine how this mistake is going to cost dear. So that's where the quality assurance bit comes in. Is a human eye as quality assured as it should be? Are there QC checks that can be done that improves the standard of reporting a pathological test? What if a ER positive cancer is reported as ER negative? We see it day in, day out, believe you or me. Every day in the clinic we see these reports that come through from any lab. Often we send it back to our colleagues and they come up with a totally different report. That's only because there's lack of quality assurance in the other labs. So what we are trying to do is to identify how quality assured the report is, whether this is benign or malignant, and these are just 4 small things that we can do on tumors. There are many, many other things that can be done. This is a real-world example of quality assurance and precision medicine. I mentioned to you, think if a ER-positive tumor is called ER-negative, what would happen? We won't be able to give you the ER-positive tumor treatment. When we started in Tata Medical Center, Paramita and her colleagues set up a very robust system of reporting. So they said, we would report as is the international standard. And then I remember I went to a conference in Goa and I was presenting our data, and our ER positive case percentage stood up to around 75%. There was a publication at around the same time in the Journal of Global Oncology which said that in India breast cancer is different because we get ER negative cancers more predominant. And we really discussed as a group, we thought, what's happening? Are we really doing something wrong? Why are 70% of our patients ER positive while the rest of the country is saying it's ER negative? We went back, we checked our QC, and we found, no, what we are doing is absolutely perfect. We then wrote to the journal and said that, look, on a set of so many thousand patients, we've done this. We believe the Indian patients have exactly the same disease as the rest of the world. We are not anything special. And believe you me, when the country started to use the right QC techniques, they also found the breast cancer types are exactly the same as it is across the country, across the world. So QC check is of utmost importance. You've got to do things as per your quality assurance, and that is where computational can help, because if there is lack of quality assurance, there can be alarms that can be set in. And then you have to have a multidisciplinary management plan. So you have to interact with your pathologist, your radiologist, other colleagues that there are, and decide on a plan of management. And this is the most important thing. You should have institutional policies on management. And these institutional policies is again a blanket policy. So it's not precision medicine as such, is it? If it is a ER-positive breast cancer, this is what you should treat. It's not personalized. It's not something that, there can be 10 different patients with ER-positive breast cancer, but you as a doctor have to then personalize that treatment, but it has to, again, follow a pattern of being in a protocol. So personalized doesn't mean that it can be off the roof. Okay, well, I won't do this, I won't do that. There has to be a set algorithm. All has to follow a policy, even though it is precision medicine. Similarly, you've got to audit your results, and again, if you want to reduce your heterogeneity, you have to have a quality assurance process. This is an example of what we did with you in IIT Kharagpur. So we identified that reporting Ki67 is a bit of a flaw. So with colleagues in SMST, we said, can we actually standardize reporting of Ki67? And this was way back. This was back in 2016. And we said, look, Ki67 reporting is time consuming. It is qualitative assessment. There can be intra-observer variation and difficult in histopathological grading. So how can we standardize Ki67 reporting? And we said we would have an objective quantification of IHC staining of Ki67. We have reproducible data, and we would use a computational algorithm. So these are some of the other computational work that has gone round across the world. And then, colleagues in SMST actually tried to do a deep learning process whereby our colleagues in pathology, led by Indu Arun, one of my other colleagues, actually has identified the hotspot. The computer then developed an algorithm to report the Ki67 hotspot. And this is not my cup of tea. This is exactly what you do on a day-to-day basis. The different algorithms are being prepared, and then look at the correlation between what the automated reporting and the manual hotspots are. Yep. So this is what we want on a daily basis. So your computational reporting should match the best of the pathologist's reporting. This is our publication in Nature Scientific Report on the computational pathology for Ki67 reporting. We did similar work on ER, PR positive and computational reporting for that. Again, these are to try and improve the precision of the work that we are doing. Right. Now clinical audit is something that proves that your precision is actually reasonable. So basically, you audit the outcomes of your report. So we audited, we said that we did this, ER positive, we did quality assurance, but the clinical outcomes is what the endpoint should be. So what I'm trying to say is that do your research based on the clinical endpoint. Is your patient actually surviving more if you're working on this algorithm? So we audited our result, and we were really happy to see the excellent survival rates of our patients with breast cancer. However, is this the precision that we are looking at? Look at this. This group A and group B are different types of tumors that we are clubbing to, group A type of tumors, group B type of tumors, HER2 positive and triple negative breast cancer. These are the 4 different biologically different types of tumors. And you can see that, the survival rate is not 100%. If I know exactly what this tumor is, why can't I cure all of them? There's 8% that are outliers. Remember, chloroquine given to 40 of you, 2 people will actually die of this. So there's still lots that we've got to understand. It's not just ER, PR, HER2, and Ki67. And this brings me just as an example as to what we have got to understand. The estrogen pathway, I said that, if the ER tumor is ER positive, we can switch it off. Is it as simple as that? There are crosstalks. There are other cofactors that are associated with it. And, any of these circuits, just like you have circuits when you look at any of these circuits can go wrong. So we have to analyze each of these on a much more basic level. And that basic analysis can often be done if you look at either a protein, which is called proteomics, if you look at the genomic makeup of that person, or basically what is being transcripted by a gene, what protein is being produced by a gene, so next generation sequencing, CRISPR, all of these are sort of genomic assessments. So we are trying to be more specific, try and see if the gene is actually producing a protein. If not, then we can actually identify that gene, that faulty gene, and do a treatment to try and as a remedy. This is again an example as to how these things crosstalk, and any of these things can crosstalk, and we've got to then think of other things that we can do to try and prevent resistance to a therapy. Now this is a study that we are doing again in Tata Medical Center. It's with a drug called alpelisib, which is a PI3K. PI3K pathway is a pathway that we have in breast cancer, which actually causes resistance to endocrine therapy. So estrogen positive cancers are given endocrine therapy. The therapy becomes resistant if the PI3K is mutated. So if there's PI3K mutation, can we give anything that would actually block the PI3K pathway? That's what we are trying to test. So again, this is what precision medicine is about. So starting from the symptom, now you know symptoms, imaging, analysis, pathology, coming to the genomics, coming to the proteomics, and then you've got new drugs that you're testing, try and block different pathways. That is what, it is a huge domain when we talk about precision medicine. You've got to choose a small area in it and start working. Similarly, risk adaptive radiotherapy, again in breast cancers, there are different ways that we can give radiotherapy to. So again, we can adapt the risk of the patient to and then give you a certain dose. Now this is my penultimate slide, I think the last few slides. Look at the sort of broad definition of precision medicine. An emerging approach for disease treatment and prevention takes into account variability of genes. We said if the genes are different, then the different pathways are going to be more active. Environment and lifestyle for each person. It actually is a very narrow sort of definition. I'm quite happy for you to go ahead with this definition, which says that precision medicine refers to the tailoring of medical treatment to the individual characteristic of each patient. So depending on individual characteristic of a cohort of patient you treat, a ER-positive cancer, this is what you should treat. It does not literally mean the creation of drugs or medical devices that are unique to a patient. It's not that, for one patient I will create a new treatment. It doesn't mean that. It means for a group of patients with the same characteristic, we would actually give you a treatment. But rather the ability to classify individuals into subpopulations, that is what we are trying to improve our precision on. Can we subgroup, substratify our classification of cancers? So that's about it. Personalized medicine is often sort of interchanged with precision medicine. You cannot personalize, as I explained. You cannot personalize the treatment of someone because for a particular person, yes, you can say that if there's G6PD deficiency, I will not give you primaquine, but that applies for not just you, for anyone with G6PD deficiency. So it's not one individual, it's for a group of individuals. And we are biobanking in Tata Medical Center. So what this means is we are banking our images, and that's with IIT Kharagpur. We are actually banking our images to look at these pattern recognition pathways. So we have the first national annotated bank along with IIT Kharagpur. We've got some research with you on it, and we've got some funding as well for it, and we've got some publication with many people like you on trying to improve the precision of giving us more precise treatment options. And this is the algorithm. So radiation oncology, radiology, nuclear medicine, these are different things that we use to try and treat cancer. And look at the right. Artificial intelligence, image processing, data analytics, molecular biology, medical physics, mathematical computation, got to work together to try and improve the precision. That is what precision medicine is all about. We're really happy that we actually started some of it with you with some external funding, and we look forward to larger and bigger grants with you.